is substance use in pregnancy, tackling disparate care through collaboration. And I'm Amy Cubbage, president of the North Carolina Partnership for Children. And I'm so appreciative of you all joining us. Again, wish we could be in person, but grateful that our wonderful presenters are able to pivot to be presenting virtually and joining with us. Before we start, please make sure that your mute is on so that there's no disruptions to the presenters. And without further ado, I would like to introduce our co-presenters. So we're just thrilled to have them here from Cabarrus County. Gina Hofert is from the Cabarrus Partnership for Children, and Dr. Russell Suda is from the Public Health Authority of Cabarrus County. Welcome to you both. This is one of my personal favorite programs, and I haven't even had a chance to meet you, to say that to you. So I'm really pleased that I pulled the lucky card to be able to introduce this session. I'm grateful for all the work you do for young children and prenatal through the young parents that you're impacting. So without further ado, I'll turn it over to you both. Thank you.
Thank you, Amy. It's an honor to be able to work on this project. My name is Gina Hofert. I get to manage the Substance Use Network project out of the Cabarrus County Partnership for Children. And then this is, of course, Dr. Russell Suda. We are in the same room, so you're going to see us glitching in and out as we move the camera. But Dr. Suda is with us as well, and you can say hello.
Hello. Good to be here.
Just a couple of disclosures. We don't have any financial disclosures, of course, to report, but I always like to note that the views that we express are, of course, the sole responsibility of the authors, Dr. Suda and myself. They don't necessarily represent the views of Cabarrus Partnership for Children or the Cabarrus Health Alliance or our funding partners like the Robert Wood Johnson Foundation. And you'll hear in and out because Dr. Suda is coming out of clinic, so thank you for that. I would love to be able to start off by launching a poll where you guys can participate in that. I'm not sure if our IT coordinators can help launch that, but I want you to go ahead. You'll directly on the screen are going to be able to answer the questions. Do not overthink them. Just really, they're anonymous, so you're not going to have to worry about your name being attached to it, but just really go with your gut reaction. As you read these, just start clicking kind of what your initial reaction is to this, because we all have feelings, experiences, perceptions, and just wanting to gauge our audience and begin to have some awareness when it comes to substance use disorder and use of substances during pregnancy. Have we been able to get anybody else to see the poll and have participants answer?
Yes, I see it, Gina.
Wonderful, thank you. And Amy, just as a heads up, we do have an official tornado watch here in Charlotte, and our entire staff and building is moving to the basement.
To the first floor. Yeah.
To the first floor.
Yes. Okay.
We are housed on the second floor, so we're going to stay on. But if you see us begin to transition, that we may have to do that. I'm so sorry.
No worries at all. Please just stay safe, and we understand. Thank you.
That could be about 30 more seconds to answer those. I love seeing your responses, your genuine responses to these questions. This was actually pulled from some research done from RTI, where they were starting to measure stigma and providers' perceptions of substance use. All right, Amy, thank you. If you'll go ahead and close the poll and let us see those results. Fantastic. So I don't know if you can scroll or not, but everybody has access to the results themselves. So you can actually scroll down and you can see those. But it really starts to kind of assess and for us to have that awareness about what we see or how we feel about addiction, about people that use substances, particularly some of us may feel differently when people are using substances while they're pregnant. And that brings on a whole different dynamic that Dr. Suda will get into when we talk about some of the root causes for the disparate care that we see when it comes to pregnant women who are using substances. Wonderful. Well, thank you for taking the time to do that. And as we're presenting, just keep in mind what this would look like if it were to be replicated in your community. How would your community partners and community members receive a program like this? If you were to talk to your legislators or your funders about treating substance use disorder or treating pregnant women who are using substances, what kind of response would you get? And just have that kind of playing in the back of your mind, because that's part of what we had to do here for several years in Cabarrus County before we could get started. I'm going to play a video for you. It is from the Picnic Project. Some of you may or may not be familiar with the Picnic Project, iCloudy. It is a statewide initiative, quality improvement initiative. And this is from one of the mothers that has a substance use disorder. And I thought it would be powerful for you to hear directly from them. And thank you for your patience as we transition.
I actually, I come from a place where my mom used, and then my children's father, he used for 13 years of our relationship, and my mom my whole life. And I always felt like, why don't they love me enough? You know, choose me, pick me, you know, put me, you're hurting me. Like, why don't you stop? And then I was humbled because never in my whole entire time that I used, did I ever love that drug more than I love my children. But every day I picked that drug over my children, and it didn't make sense to me. And people would say, you don't love your kids enough, love them more, pick them, you know, and it wasn't that easy. And that's an understatement, you know, like it's almost like somebody else was driving my body. And not one day did I ever love anything more than I love my children. They're what's saving my life right now. But the judgment and the times that was said to me, I felt that, you know, I've been there, and I've begged, please love me enough. And, you know, then I was humbled with the reality of it. Yeah.
So one of the things that I really had to work on when we first started this project was realizing how people felt about pregnant women who were using substances. And Dr. Suda can really talk about that journey, even for him as an obstetrician. And so even you as a provider, if you're working with mothers and families that are using substances during pregnancy or even after, what are your perceptions, you know? And begin hearing what that experience is really like for mothers, what they really want and how they struggle with that chronic illness. And we'll get back to. I'm having trouble sharing my screen. I'm wondering if the host. Are you guys able to see that?
Yes.
Thank you. Thanks for being patient. So here in Cabarrus County, given the context that we were seeing a rise in substance use disorder, opioid use disorder particularly, and with even during pregnancy, was to develop the Substance Use Network, which we call the SUN Project, in order to have, and these are the key words, a compassionate, cross-sector, collaborative system of care that is using best practices in order to be able to support the health, the safety, the well-being, and ultimately the recovery of pregnant patients with a substance use disorder, and extending that past delivery to their infants and their families. So that was the goal of the SUN Project. And we'll talk a little bit about how we've actually let that come to fruition and become a reality for us. We do have several funders that I want to bring your attention to, a lot of it because it's driven our work and our focus. And our primary one is the Cross-Sector Innovation Initiative from the Robert Wood Johnson Foundation, and that is administered through the Center of Sharing Public Health Services and Public Health National Center for Innovations. Their goal truly is, and I know it is for Smart Start as well, looking at systems alignment, specifically with public health, within healthcare, which includes behavioral health, and then social services, making sure that all those systems are working collaboratively and aligning their goals, their funding, their data sharing to improve population health, well-being, and then of course, equity for all. And they want this all driven by the voice of community members. And that's been hard for us. Getting a pregnant woman who is using substances and managing pregnancy, managing the addiction, managing the stigma, to come and be able to be part of the programming and use their voice has been difficult. And it's taken years of Dr. Suda building trust within the community and within partners and with his patients in order for them to begin to feel comfortable saying, this is my story. This is what it really looks like in my home, so that we can begin learning and programming more efficiently towards that. We're also funded by Smart Start through the Cabarrus Partnership for Children, as well as some private donations. And that's been really cool to see. As Dr. Suda has gone around and gotten partnerships throughout Cabarrus County, there have been some private agencies who have said, wow, we really believe in this work and this mission. Here's a donation, unsolicited and unasked. So that's a nice supportive feeling from your community.
I guess it's my turn, and I'm going to talk about the opioid epidemic, which kind of has fallen into second place behind the COVID epidemic or pandemic, but nevertheless continues to rage. And looking at the opioid epidemic, I'm sure everybody has done their share of reading on why we have an opioid epidemic. And just to quickly do a thumbnail sketch of why, we just got told that the tornado warning has abated, so that's a good sign. You know, the opioid epidemic really got rolling in around 1990, and it came out of some medical literature articles that talked about the ability to treat chronic pain with extended release narcotic analgesics that were purportedly not addictive, but it turned out to be very addictive. And the development of these very addictive drugs by pharmaceutical companies, and the proliferation and prescription of these drugs by certain pill mills, and the endorsement by the FDA and letting these drugs hit the market a little too soon, maybe way too soon, and not doing an adequate amount of research on them. But whatever the case may be, the opioid epidemic we know has occurred and continues to go on. And what we really want to look at now is what happened during this opioid epidemic. Well, guess what? Women moved into the #1 spot in becoming substance use disorder treated patients over men. This has always been considered a male problem, going back to the 1960s when methadone clinics were kind of identified as a way to deal with them. A lot of male heroin addicts in urban settings was your classic patient. But now, by 2010, women were entering substance use disorder facilities at a greater rate than men. If you look here, from 1992 to 2012, a couple of things happened. The percentage of women entering substance use, reporting opioid use increased from 2 to 28%, a 14-fold increase, so 1,400%. In terms of using prescriptive opioids, it went from 1% in 1992 to 19%, a 19-fold increase. These are huge increases. And after 2010, of course, the opioid prescription restrictions started hitting, and we've seen a reduction in opioid prescriptions, but black tar heroin coming up from Mexico fanned the flames, and the women were using heroin and using IV drugs like men were. The big problem here, I mean, amongst other problems, is that 80 to 89% of women with substance use disorder don't use contraception. So there's a high unintended pregnancy rate, of course, especially since many of these women, at least a certain percentage of these women, use sex as a means of acquiring or gaining access to these drugs, and of course suffering in the process of criminality and trauma and all the things that we know occurs to women because research moved towards women and out of the realm of just men. So we have a non-contraceptive use rate that's twice that of the general population with high pregnancy rates. Okay, next bit. And what does that mean, pregnancy in a gestating baby? Well, let's look at it. Fetal exposure to narcotics and the predisposition to opioid use later in life is very well described. If we look at a whole panoply of drugs, let's look at just alcohol. There was a 14-year study that looked at an increased risk of alcohol use that exceeded alcoholism in the family as a predictor of being alcohol user in adolescence by the National Center on Substance Abuse and Child Welfare. The American College of OBGYN reported in one of their committee opinions that prenatal exposure to marijuana increased the likelihood of marijuana use by age 14. But importantly, on points 4 and 5, we see a manifestation of in utero exposure includes impaired cognition and increased sensitivity to drugs of abuse and a smaller brain at birth. I mean, these are very, very strong anatomic and physiologic intellectual pieces of evidence that a gestating baby is suffering dramatically from exposure to substances. That includes alcohol, of course, but marijuana, and marijuana tends to get a pass these days because it's being legalized a lot. And I'm forever trying to tell women that marijuana does not get a pass for nausea and vomiting in pregnancy, because marijuana is an cannabidiol drug that competes with endocannabinoids that direct the migration of neurons into various centers in the brain and direct synaptic health between neurons in the brain and longevity of neurons' lifespan in the brain. So marijuana is certainly included in that group of drugs. So if we don't pay attention to what's happening to babies in utero, they will be born and then appropriately, very appropriately, Smart Start says, let's get started early and work from 0 to 5, but you have already a damaged piece of goods in the central nervous system that's being turned over to you. Why not start in pregnancy and get these women on stable narcotics like buprenorphine, like methadone, which have a great track record in not causing long-term behavioral developmental milestone problems in these babies. Next slide. But what was the failure of in pregnancy with substance use disorder? Well, first of all, if you remember, before 1990, there were very few pregnant patients, relatively speaking, with substance use disorder. It was more men than women. But when women became, into that flock of people using prescriptive narcotics, then we saw pregnancy being involved and babies gestating being involved with substance use disorder. The pregnancy, however, the prenatal care for these patients was really not well developed. I trained in the 1980s at Hopkins, and we really didn't discuss substance use disorder. Most of these patients came in from methadone clinics. They came in late in pregnancy without prenatal care, and they delivered, and they were rare. But as the numbers increased and the severity of the addictions worsened, we didn't see prenatal care marching along with it. And it's primarily because obstetricians were not adequately trained in having a comfort level with these patients, and fearing very greatly that they were at a great deal of medical legal liability managing patients who were actively taking drugs that were not good for the baby's health and well-being. Also, if you feel like the obstetricians were uncomfortable, the consultants were even more uncomfortable, because for them, pregnancy was a no-no. You just stayed away. And that included psychiatrists, that included pain management people, that included, outpatient treatment programs to a great extent, where methadone was prescribed, although they really gave more help than the other two entities. But the consultants really, it was not uncommon to hear from a consultant, oh, we don't treat pregnant women. When she delivers, yeah, we'll see her and we'll manage her. Well, that's after the horse is out of the barn. We've got a problem here, and babies are being born with significant imprint from that substance use during pregnancy. And in 2014, I was representing 3 counties in the Pregnancy Medical Home Initiative, which was a all-inclusive North Carolina medical program that was trying to improve the quality of care delivery to Medicaid pregnancy patients and cost effectiveness of that care. And we did a 1-year clinical pathway, authoring a clinical pathway on how to manage these patients, because there was nothing out there. And everybody was shocked, including leaders in UNC Chapel Hill, Duke Medical Center, Wake Forest, East Carolina University Medical Center, on the very little bit that was in the medical literature to guide obstetricians in managing these patients. So very little research had even been done on managing these patients. And finally, methadone, which we can't prescribe, we still can't prescribe for narcotic substitutive therapy. Buprenorphine came along, which is a drug we could use, but not until the year 2000. And so we would expect that, obstetricians and consultants would pick up the waiver there on buprenorphine and begin using it, but such is not the case. The American College of OBGYN reported in February of this year, was that 3 months ago, that less than 2% of the obstetricians in the United States are waivered to do buprenorphine. It tells you that there's just not much participation in managing this patient population yet. Next slide.
And can I ask you, Dr. Suda, so one of the things that impressed me the most when we started this project was when you shared your journey. So here you are talking about the medical legal liability that obstetricians were afraid of. Many, even to this day, less than 2% of obstetricians are waivered. Talk to me about why. Did you experience that? What kind of made you shift? And then what did you see as a solution?
Well, when we put out this clinical pathway, I realized you can't manage these patients without a heavy dose of behavioral health, a heavy dose of social services, especially. The most complex part of their life is where they live and the difficulty in getting anywhere for any kind of care. So the problem I got into was, how do you bring all these entities together? And I happened to do a pathology residency between 78 and 81. And as a pathologist, I used to go to tumor boards. And in a tumor board, you would manage cancer patients by having all the specialists sit around a table and discuss a single patient at a time. And everybody would put in their expertise, and a plan would be implemented around that table. I thought, you know, that was so great because cancer patients are highly complex, but you'd have the radiation oncologist in that room, you'd have the oncologist, you'd have the oncologic surgeon in that room, you would have social services in that room, you would have pathology in that room, radiology, and you know, it was so efficient in putting together a medical plan and getting it off the ground that I thought, well, why wouldn't we want to try to apply this concept to these very complex pregnant patients? It takes more varied expertise to manage a woman with substance use disorder in pregnancy than it does to manage a cardiac patient with, you know, level stage 3 cardiac patient, which is, you know, very serious disease and can be even terminal in pregnancy. But if I get a good cardiologist, I'm on my way, you know. But in this particular arena, I have to have social services in many different areas of social service. I have to have addiction medicine help. I need behavioral health because, you know, 80% of these women on average have a psychiatric comorbidity besides their substance use disorder. So, I mean, I need all these patients. And now with our monthly care coordination committee and putting this collaboration together, this network, which by the way, took 4 years to do, and that's what's on the slide there, it is wonderful because I'm really drawn back to the years of the tumor board where we sit around and learn from one another. We learn where we can cooperate. We learn how we can, you know, overcome all kinds of barriers that otherwise would just stop patients in their path. And we have, God has blessed us. We're, you know, with about 20 patients delivered now, 30 patients in the program. We've got 95% of those women delivering beyond 35 weeks. And that's, you know, a very high, good pregnancy rate of near-term and full-term babies because we are coming together. So that's where that idea of collaboration came for me. It came out of pathology and tumor board work that I have done.
And do you mind talking through the medicine? So one of the things I had to learn when I first came on board was what can you do for a mother that has an opioid use disorder in order to manage the addiction? And that's the medical piece of it that I didn't understand. And then how you were feeling, were you able to get people to work with you? So if you'll explain the medical piece first, and then we'll talk about what your response was from the community.
Yeah, you know, by the time a woman is pregnant with a substance use disorder, the time she's developed a substance use disorder, and it goes for men as well, they're really not taking their heroin anymore for a high as much as they're taking it to stave off physical withdrawal symptoms and cravings, which drive them, you know, every 8 to 10 hours out to get more drug. When we provide buprenorphine, it's got like a 36-hour or more half-life, so that we can jump on those receptors with the buprenorphine medication and curtail the strong cravings and the physical withdrawal symptoms so that mothers can focus on being mothers. You know, they got this new baby coming in and they got all kinds of ideas and thoughts and feelings and preparations to go through, just like any other mother. But if they're beleaguered by cravings and physical withdrawal, they're not going to be able to pay sufficient amount of attention to that to get the job done. So what we do when they come in is right away begin discussing buprenorphine with them and encouraging them to go on it, because you know, substitution therapy and harm reduction philosophy is so much more effective than abstinence. Abstinence isn't even recommended because when you put a woman into abstinence subtly during a pregnancy, that baby's going to go through withdrawal, and the baby's a lot less tolerant of that than the mother is.
Thank you for explaining that. I remember when we first started talking that you were excited about what you could do as a doctor. You know, you said, as far as medicine is concerned, we can get very good outcomes. My biggest concern is that I can provide the best care in a 15 or 30-minute appointment. I know they can be longer with these patients, and you give them that extra time. I can provide the best care in that office, but if they go home if they even go to a home, but if they go back out to toxic environments, there's very little that we can do in order to get her on a road to recovery. So as you started going out and saying, I would like this tumor board approach, I would like to be able to talk to DSS and the judicial department and to pain management. What were some of your initial responses from community members and other partners?
Well, everybody was concerned that they were going to be dumped on. That's the term that's used when, you know, you end up inheriting a patient that you really feel ill at ease managing by yourself, and nobody else will step to the plate and help you with them. And that's kind of the way, you know, the management of these patients have been going. A very siloed effect. And when patients did, and when providers did offer to help, they felt like they couldn't unload the patient or couldn't have communications with the original caregiver. And so the patient would be ended up feeling, the consultant would feel like, oh, now I've got responsibility for this patient, and they would be worried. So what really I had to do when I went out and talked to all the different people for those 4 years was tell them, no, this is a network. Nobody will be, I mean, the obstetrician will have primary responsibility for the patient, but that's just because he is in the middle of the medical home team for this patient. And he's going to be making sure that the various inputs of consultants are coordinated. And it's a coordinated collaborative care for these patients that works. There was skepticism. In fact, several docs said, I got to see it to believe it, you know. And I understand from where they're coming from, because I was in the same milieu myself with the same quandary that these patients are never going to get any care because nobody wants to cooperate. But when we formed the network, we went out and Gina worked very hard with Mr. Mark Botts from the University of North Carolina School of Government. And it took them a year to come up with release of information, confidentiality documents, memorandums of understanding to work together legally. But once those documents were in hand and people started seeing that, my gosh, we can all just contribute here and nobody gets, you know, the end responsibility for managing the patient in an isolated fashion, then people were willing to come on board, including DSS. And, you know, DSS plays such a huge role. It's a very difficult role trying to assess whether a baby is safe in the confines of a substance use disorder family, because ultimately they're very vulnerable, of course, and we don't want to split them from the mother, but sometimes it's absolutely necessary. But by including DSS in our preliminary collaborative work and our monthly care coordination committee meetings, we've begun to actually open up discussions about, hey, how can we as obstetricians and consultants to the obstetrician during the pregnancy begin to contribute favorably for this patient's ability to maintain custody of the baby? Because if she's coming in every week or every other week, every third week, and getting her care and getting her meds, and there's a couple slip-ups here and there, but that does not mean that they're an incompetent mother. And so we were getting into discussions with them. We're getting into discussions with criminal justice. We have, two different judicial systems, the family's judicial system and the superior judicial system of Cabarrus County, sending over patients. We got law enforcement encountering people on the street saying, oh, I can see you're pregnant. The Sun Project would love to see you. And we've got, district attorneys helping bring people to the clinic instead of in front of a judge for sentencing. It's really quite heartening to see the really very, very infectious nature of the desire to help these people when people come together and realize that nobody's going to get, the risk of a medical legal case levied against them because they're managing this patient by themselves, and nobody is capable of doing that.
And I often get from other communities, how do you get something like this started? And I know at the beginning when we were working, I heard your vision and my thoughts were, okay, how do we get to your tumor board? How do we get partners to collaborate, to buy in, that it's worth investing? And we were able to use a guide that was published from SAMHSA, and we'll link you to that resource at the end of the presentation. But it's phenomenal. If you're able to get funding and can get a program coordinator who wants, a guide on how do you get from point A to point B, that was my role. I was able to use the SAMHSA framework and say, okay, I've got the champion on hand. I've got Dr. Suda. We've got the patients that are out there. We have to figure out how to recruit them. But how do I get this network of providers going? And this framework really, really did a lot. And we'll go into that a little bit more as well.
And finally, I just can't tell you, I've got a wonderful staff. Gina is a very great program manager. I got a wonderful licensed clinical social worker who does my depression, anxiety counseling, and is the liaison to psychiatry or behavioral health. Social service people, Ann Benfield is the head of Cabarrus Partnership for Children, does a great job bringing all kinds of things like parents as teachers, ABC, all these different social service programs into the mix after the baby's born. And so I've been very, very fortunate to be amongst such great people. But when a woman comes in, it's not just trying to neutralize in a sterile fashion the stigma that's normally associated with their presence, substance use disorder in a pregnant woman. I try to bring joy into it. I tell them, absolutely you can have a full-term healthy baby. It can be a game changer for your whole life if you really want to make it a game changer. And these women look at me with a hopeful sense of maybe I can change my life, and maybe this pregnancy is where it's going to happen. And I can't tell you the number of women who said this baby has just changed me around because it has given me hope. And so we give them hope. We start with the most primal of all communications, and that is that you can have a healthy full-term baby just like any other mother. Because many of these mothers come in and think, oh, I've been using drugs for the first 3 months here, my baby's lost. It's just not true. The sooner you get after stabilizing that baby at mother's womb, the better the outlook for that baby at the time of birth. And I give them our whole staff, our whole team gives a reassurance of support. We give them buprenorphine through the first year after the delivery, and we don't have a bell go off and say you got to get it somewhere else now. We make sure they transition into primary care or somewhere where they can get a ready source of buprenorphine, because we don't want them to suddenly find themselves out there without their medication support. And we always say, if you want to get off of your medication and completely abstain from it, that's a great goal, but don't try that in your first year when you got a newborn baby. And finally, we talk about the custody. And we are learning. I will tell you, the toughest area that I think I've had to learn is trying to understand the custody issue for moms and babies, because I never really, had any experience with safety issues. So we're working very hard on trying to console mothers about custody and being an advocate for them to keep their baby. Because if you look at the foster care literature, babies that are taken away from their biologic mothers have a higher risk of substance use disorder later in their lives also. That transition and the different, punctuations of care, for foster care, back to the biologic mother, back to foster care. These things do a very hard number on these children. And we're trying to make it such that if we get the mother into a recovery position and sustain her, she can keep her baby, because that's what, foster care originally, that's my understanding in reading the literature on them, that they really wanted. We have gotten the preterm birth rate way down in the Sun Clinic, but it's not perfect. When there's a 30% preterm birth rate out there in some literature areas on substance use disorder and pregnancy, it makes you feel good. Harm reduction is what we emphasize. We're not interested in abstinence, we're interested in harm reduction, and that's buprenorphine therapy. and the ladies do very well on it. There's different types, there's mixtures with naloxone, there's non-naloxone, and there's sublingual tablets and films. And so we oftentimes are going through different trials until we settle on one, but the whole time they're getting a steady dose of buprenorphine and their baby is stabilizing. I hope that's helpful. Is there anything else that?
No, that was fantastic.
Okay.
I know we're looking a lot at root causes, and so we talked about the stigma and the disparate care because providers just were not wanting, for a variety of different reasons, to care for patients, and you went through that yourself. And we know that intervening during pregnancy is really going to increase so many factors for the baby once it's born. But why is it that you want to intervene during pregnancy for the mother in her road of recovery? Why is that time so pivotal? Can you talk about what we've seen in the literature and in your personal experience?
Oh, this is a very big point. Trying to begin a mother on the road to recovery at the time of delivery is almost hopeless. There's just too much going on after the baby's born. Our goal in the Sun Clinic is to get women on a behavioral health pathway when they need it. And like I said, most of them do need some behavioral health counseling and sometimes pharmacological treatments as well. We get them on a social service pathway. We try to figure out in a hierarchical fashion, what is their most pressing need socially? I mean, if their roof is leaking and or they're in a situation where they're having trauma when they come home at night because of the poverty in their neighborhood or because of a domestic violence, we can't hope that this patient will ever follow a medical plan when those very, very primal needs are not being met. So what we try to do in the pregnancy is not solve all these problems, but get the mother on a pathway so that when she delivers, the case management people at the hospital can say, okay, you're already on this pathway. We want you to have an appointment over here and over here. We're linking you up, and we see them back, and we also reiterate those pathway commitments. And we have a social service behavioral health overseer who tries to be sure that the patient does not get overwhelmed. There's a lot of literature on there. It surprised me that so many of these women get overwhelmed by, very altruistic calls to help them with this, that, and the other thing, and their schedules get overburdened, and they end up dropping out of most of the care that's offered to them. So we try to do a hierarchical assessment of what the patient needs, stay with that hierarchy, and move down the line as those more primal needs are met. And I think that's very important and something that's easily missed in managing these patients.
Thank you, Dr. Suda.
Mm-hmm.
I know one of the things that we talk a lot about as well is that, ironically, we postulate as in the Sun Project that this small group of patients that experience the biggest disparities in care may very well be the key to upturning the opioid epidemic, because that is the time in a mother's life where they're most motivated to change behavior that they were not able to do at other points in their life. And we don't really know why biologically, but we know from the literature that that is just what we see, that during pregnancy or becoming a mother allows people with substance use disorder to finally be able to make those changes, break from that abusive relationship, stop smoking, stop using substances. And so with the use of buprenorphine, they're able to do that. And then we can break that cycle that we often see when it comes to substance use disorder. Thank you, Dr. Suda. I'm going to share not the whole video, but we did have the North Carolina Impact Center come and do a video of our project. And I think it paints a good picture of our work.
Opioid misuse is a crisis in North Carolina. Leaders in one county are working to help a particular group with recovery from their substance use disorder. This is NC Impact. I'm Anita Brown Graham. The opioid epidemic is a public health crisis that has affected every community in North Carolina. Opioid abuses by those who are pregnant pose special concerns. In Cabarrus County, a group of changemakers have come up with some innovative ways to respond. NC Impact's David Hurst looks at this program that creates a network of resources to help women on the road to recovery.
Galana Gillette has dreamed her whole life of becoming a mother. She's now pregnant with her 8th child, but what happened during her first pregnancy put that dream at risk.
It happened really more or less whenever I got pregnant with my first set of twins. I was sent home, of course, with a nice bottle of hydrocodone, and I had my first C-section. So after that was whenever I actually started using, or I should say abusing, opiates. And then after that, it just slowly grew to where anything you can name, I've tried. My grandmother was diagnosed with cancer. She's more like my mother. She's the one that raised me. And then my dad was murdered in Charlotte. He was a string of murders that happened. He was just washing his car, so it wasn't like, he was a good man. He wasn't doing anything wrong. Once he got murdered, I had just told him that I was having a boy and a girl, and I didn't even get to tell them their names. So, of course, it took its toll. I was already getting out of a really bad divorce. So, and then also going through a custody battle with my oldest son at that time. So, between everything, like I said, when they sent me home with that bottle, I just didn't want to feel anymore.
All of Gillette's children are healthy, but she lost custody as a result of her substance use disorder.
After going through what I have now, of knowing that they're not at home and still fighting addiction, I don't like putting it into words because I don't want somebody to think that I don't care about my babies. Or I've lived all my life, it feels like, to be a mother and to do for them, regardless of how hard it got. And I've not always had their dad there 24/7. So to know that, like I said, I thought that's all I've known is being a mom, and looking in their rooms now and seeing they're not there, and this is all because of a choice that I made to do drugs or to do a drug, regardless, even if it's 1 or 10, it doesn't matter. But they're my life, and I want my life back.
Galana Gillette participates in the SUN Project, a program run here by the Cabarrus Health Alliance. It provides a network of resources to pregnant women struggling with substance abuse disorders.
The whole thrust of the SUN Project, once it got underway, was to get the care going during the pregnancy so that we could help avoid delivering a preterm sick baby that was only going to exacerbate any hope or attempt on the part of a caregiving team to put the mother on a recovery pathway.
The program creates a network connecting mothers to doctors, social services, hospitals, and other healthcare providers.
Most doctors traditionally would say, I will do the medicine, and then I'm going to refer out for all the other stuff. That was kind of the old way of doing things. Dr. Suda really kind of is a pioneer in saying, the old way's not working. I would like to be at the center of providing care for her, working collaboratively, knowing that I need your expertise in other areas to provide the best care for her.
The rate of pregnant women misusing opioids across the country has quadrupled since 1999. Untreated opioid use disorder during pregnancy can have devastating consequences for the unborn baby. The Sun Project helps patients get connected to medication-assisted treatment. It helps prevent withdrawal during pregnancy and minimizes the unborn baby's exposure to dangerous substances.
Women that are struggling with opioid use disorder, I mean, remember, it's an illness. And women that are struggling with this feel tremendous guilt and shame, and they need someone to like reach a hand out and say, there's hope, we have treatment. Actually, there's great possibility for recovery for both you and your baby, and so we need you to come into treatment.
It's nice to know that in the community, the word is getting out that you can come here and you're not going to get shamed, you're not going to get turned away, you're not going to be told that there's 25 hoops that you need to jump through before someone will actually see you. And then you also get a physician who actually says, I'm really proud of you. Thank you for coming. This makes you a great mom. And I don't think they were hearing that before.
It's been about a year since Galana Galette started the Sun Project, and she now has new dreams to continue on the path of recovery and to bring her children back home.
I feel like if anything now, especially after being the past year, I've tried very hard with my sobriety. You're not going to make the change unless you want it. To know that I can do this and that they're worth doing it for. And they deserve it.
You can actually access the entire video on the PBS website, and that link is available through the PowerPoint that was given. So let me get that up and running for you guys again. And if you're having any questions as we're presenting, feel free to put them in the chat box. We have some great facilitators that will help us manage those, but we'll also have some time for question and answers at the end as well. All right. I don't know about you guys, but I've been on workshops before, and an hour and a half can be a long time. So I would love to give you about a 3-minute break. So if we can come back at 2:30, Amy, with your permission, to give those on the other end of the screen a time to go get a cup of coffee, use a bathroom break, and then we will come back at 2:30. Is that okay with you, Amy?
I was trying to unmute. Yes, that is absolutely fine, Gina. Thank you very much.
All back at 2:30. right, welcome back, folks. Hopefully you were able to take a little break. We're starting to get used to presenting virtually, and sometimes we forget that even virtually we have we need a brain break and being able to get up and move around. So thank you for sticking with us. We wish we were in person with you, but this is the second best. So Dr. Suda, I will ask you a little bit about what the Sun Clinic actually looks like. We can go over some of the services, and then I'll get into the governance piece of it and what it looks like to bring about a collaborative network in the community. So tell us a little bit about what you're able to do at the Sun Clinic.
Hi. So Jamara Ishmael has
when a patient comes in with a substance use problem, she immediately gets entered in as a Sun Clinic patient. We spend a great deal of time, especially up front, trying to understand how it developed, where they are in that process, how much they're still using, because we have to, substance use disorders come in various levels of intensity. They're mild, moderate, and severe. We kind of try to gear certainly our pharmacotherapy to the patient's use and the level of use and the recent nature of the use and where they are mentally about stopping. What's really nice about pregnancy is I recall ever meeting a mother who's come in and said, well, I'm pregnant, but that's not going to stop me. I'm going to just go just the same or take more. They're all interested in making their pregnancy a source of renewal. And it's that hope in a baby and having a healthy baby that I believe underlies that desire. So we have our social service, a licensed clinical social worker, see the patient. She's a depression, anxiety counselor. She gets into their background, makes an assessment as to whether a psychiatric behavioral health consult is indicated right off the bat or whether she can manage it for a while. I talk to them about buprenorphine and start them on induction doses. You got to start off slow because you can put somebody in a withdrawal if you give too much buprenorphine too quickly. So once they get those two assessments done and a general first registration visit for obstetrics assessment done, we can sit back and talk collaboratively in our post-clinic conference about any nuances to this patient's presentation that need to be addressed. And so often nuances of, relationship problems, residential problems, childcare problems, transport problems, et cetera, have to be addressed so that they can overcome those very primal needs in order to even show up for prenatal care. What buprenorphine does for the obstetrician is it provides the obstetrician a real strong encouragement for that patient to return on a regular basis for prenatal care. And through those frequent encounters, we can really step into the patient's life and make positive changes.
And what's really nice at the Cabarrus Health Alliance is that they can get all of those services in one location. So they get that prenatal care, they have that case management, they have access to behavioral health counseling, they have the help of a peer support specialist, and that is someone who used to use substances, is in recovery, and can really relate to patients on a whole different level that most providers cannot. They are just able, they know the world, they've been there, and they seem to be able to build trust and connections that sometimes we just can't as providers, and that's been really, really helpful. We can connect them with intensive outpatient therapy, and then we can get psychiatric consults for them. And this did not just come up like this, that took years of partnerships and MOUs and building trust not only with patients but with providers in order to make this work. And what you really want to be able to identify in your community is, do you have an OB champion that is willing to do this? You'll notice Dr. Suda say, I can do the medicine, and then most doctors stop there, not because they don't want to, but often what we hear from other OBs and other providers is, I don't feel I have the capacity, I don't have the training, I don't have the support, and so they're kind of scared to do that. So what we've built following that SANSA framework is this governance structure that actually connects the clinical arm or medicine that often operates in its own silo with a governance arm, that oftentimes you'll see in the community, you've got everybody else working in coalitions, on a substance use coalition, you have your community partners, but rarely do they connect. And if they connect superficially. I'm going to send a referral, maybe you'll get some information back, but you rarely see them sitting at the same table. You often don't have doctors sitting at that same table with the social workers and with our community partners and our nonprofits. And so our monthly care coordination team meeting is that link between that, again, bridging, aligning sectors and connecting sectors. So it's that link between what's happening in the clinic and then all those other social determinants of health that we need to be able to address in order for the medicine to work. And so here you can see through a monthly care coordination team who all of our partners are. This did not come about easily. When you were talking about protected health information, HIPAA, 42 CFR Part 2, which is the federal level of regulations that legally protect information above and beyond HIPAA specific to substance use. And then we have in North Carolina a set of state level regulations that limit providers' ability to share that information. All of that forces all of these legal teams, when we approach them, to say, we're really not allowed to. We'd love to collaborate with you, but we really can't legally. We're not allowed to even tell you if they're a patient. And Dr. Suda would often share stories that he would send one of his patients from his clinic. At the time, the behavioral health center was next door, and he'd call to say, hey, did my patient get there? And they'd say, we can't tell you that. He's like, what do you mean? I just sent this patient down. He'd have to walk down there. So that level of inability to speak fragments care. And although those regulations are intended to protect the patient and the provider and those agencies, rightfully so, it can also impede care. So we had to find a legal way to be able to share information adequately while protecting patients, providers, and agencies. And so we have a memorandum of understanding that all of the legal teams approved and were okay with, a release of information where the patient is empowered and has the consent to say, yes, these agencies can work collaboratively and share information in order to coordinate my care. And that has been the game changer that most communities, when they come to us, say, we can't do that. And so it took that help by a legal consult. I can tell you that is what's stopping most other communities. You have, your big hospital systems, legal teams saying, we have concerns about violating SUD, HIPAA. It's just so much easier for lawyers to say no. It's just easier to say no in any profession, not to point fingers at law. It's just easier to say no. And so it really is going to take that champion like Dr. Suda was here, and then coordinating that, with some funding so that you can have a coordinator to coordinate all the partnerships and then the legal aspects of that. So we were able to develop an MOU and that covered for partners, a release of information for those patients. And that really was what kind of tipped us. And like Dr. Suda said, that took us 12 months. The project that we modeled this out of for Vermont, it took them about 2 years. So when I touched base with her, she was like, yay, 1 year, that's amazing. And the reason we could do that was because we were basing it off of their work. And that's part of our goal, is to be able to share this so that when other communities are thinking, maybe this is something that we can bring to the mothers in our community, use our lessons learned, use what we've done so that you don't have to start from ground zero, but to move up from that. I know one of the questions as we were submitting this abstract was, how have we responded to this issue in the context of COVID-19? And much like your work that you currently do, obviously we've had to move a lot of our work virtually. So that included our governance collaborative meetings. We moved them virtually. One of the lessons learned that I found was that engagement really goes down. Even with this, I can't see your faces. I don't know if you're understanding, not understanding, if you're relating, if you're not. You can't read the group. That makes it hard when you're trying to build trust, when you're trying to build partnerships, when you're talking about sensitive issues. Oftentimes in communities, you have years of past where some agencies get along with others well or don't, just history there. And it's hard to do that virtually. And so what we found was good after a couple of years was moving from a large group where you had 30 to 40 participants. It looked great on our grant reports to say we had 40 partners at our meeting. What happened is people are less likely to unmute and start talking to each other then. So we moved to smaller groups, and in those kind of smaller settings, people just really would feel more comfortable unmuting and saying, hey, let's work on this, or this is what we've seen, and that's helped us. We have moved the care coordination team meetings virtually as well, and our biggest hiccup there was finding that something that was HIPAA compliant. Zoom wasn't meeting the criteria at that time. I don't know anymore. So we ended up using Teams, another platform. Again, we're not advocating for one another. The thing being just making sure that the platform that you use is HIPAA compliant. And then for patients, they were able to do some virtual meetings, and they tend to use that. They want to see the patient. Urine drug screens are important. Being able to check the baby in utero is important, and so they tend to use that. If that patient misses the appointment, they'll try to do one virtually, kind of as a backup. And one of the things that impresses me so much about the clinic here at the Cabarrus Health Alliance, which I've never seen before, is they kind of give patients a window of when they come in. They have complex lives, getting rides, childcare. It's hard for them to get here. So, if you say your appointment is 11 and you're 15 minutes late, you're not getting seen, forget it. You'll never get to see your patient. So they've been very flexible about giving them windows of when they can come. And if they're past that window, they often do it virtually. And that's actually opened up a lot of doors for them. And then we have a lot of our community partners who are dropping things off directly to patients. So that's been our response. One of the things that we did as part of our framework to assess what is going well, what can we do in our community to start a program like this, is we did an assessment. It is a validated tool with SAMHSA. You get it from that same guide, in which it outlines these 20 best practices. And again, for someone like me, where my job is program management, how do I get the clinician who wants to do medicine into a world of collaboration? This tool is fantastic. These are the 20 things that you should be seeing in your community in order to provide the best care for the management and treatment of opioid use disorder in pregnancy. So to what degree are these in place? We use this in order to assess, what are we doing well? What are some areas of opportunity? And so I'd like to let you look at these, and I'm only going to give you a sample. So we're going to have the host pop up another poll, and be thinking about your community and answering a sample of these to say, do we have this in place? And it is okay to say, I don't know, because if you don't know, that's useful information to have, because if you have that available in your community, but people don't know about it, it's not very useful. So even that can be useful. So I'm going to give you just a few minutes to read through some of these best practices and thinking about your community. To what degree do you see this in place? Not at all, to some extent, yes, this is fully in place, or unsure. And from what I can see here, it says sure for that last one, and it should be not sure or unsure. We'll take about 30 more seconds and then we'll close the poll. Sarah, I think you're the one running the polls, but if you want to go ahead and close it or end that poll, and if you'll display the results. Wonderful. This is really cool. So if you'll look at the first one, you can scroll down and see the results as well. For a lot of you, that very first one where it says it's appropriate to give pregnant mothers with OUD medication-assisted treatment, even though the baby may experience withdrawal symptoms at birth, many of you see that they had that to some extent. You'll notice that some still say, no, this is not considered appropriate in our community. And that's a big piece to being able to bring something like the SUN project to the community. That second one, where pregnant women with substance use disorders are identified, this is a huge piece. Look at that, 55%, almost, 70% of those on this presentation are saying, we're not even screening for them. We don't even know that they exist. And this is a big thing with the Cloud Initiative, the Picnic Initiative, is that OB practices or practices in general are not screening. We don't even know that they're out there. And what we hear from providers is we're afraid of once we know about them, right, there's that kind of legal piece that they're responsible for them. But once we know about them, we don't know what to do with them. We don't have a SUN project in whatever county it is. We don't know where to send them. We don't have the capacity to serve them. So that is not unusual that most of you on the call are experiencing that. The appropriate levels of care are available. You can see that, a small percent of you have that in place, or only 16%, about 41 to some extent, which is what we see here in Cabarrus County. We don't have the full realm either. MAT is understood and accepted as evidence-based. You can see that we have, 16% saying not at all. About 34% saying, yeah, to some extent. And then we can see that only 20% say, yeah, our providers have accepted that is the best practice. And then a formalized system of care coordination between systems is in place, something similar like the SUN project. And we can see that, only 8 of you on the call have something in place in your area. So this is really an opportunity to expand something like this into your community. And if you do an assessment like this, you can see where you are. You can kind of get that baseline. All right, and you can close that poll and stop sharing that. Thank you so much for facilitating that. You can see with us, this is what our results look like. And at the end of the day, for someone like me as an evaluator, I'm wanting to know, does this work? Is this worth our time? We've invested, like Dr. Suda says, 4 or 5 years into this, a lot of funding, a lot of resources. And what you'll see in the blue there, that was our baseline that we used to see what areas we could grow in and what we were doing well. And then that's across the 20 best practices outlined by SAMHSA. And then in yellow, that was our 1-year follow-up. And in every single one of those 20 best practices, the cross-sector collaborative assessment, which measured across various different sectors, not just in one practice, but we're looking across social services and all domains, there were increases in that, demonstrating that within a year, we had an increased level to what extent these best practices were in place. And I've been doing collaborative work for quite some time, and I've never seen in 1 year system level work increase that quickly. And I think that's not to credit me in any way, but rather the investment that Dr. Suda had put in prior to us building the formal structure. That was buy-in that he had gotten from the community and trust that he was building with his patients. But you can use something like this to determine and to track how your work is going. So to leave you with some resources, if something like this interests you, we are always available and love answering questions. The first thing I would direct you to is that guide, which is called The Collaborative Approach to the Treatment of Pregnant Women with Opioid Use Disorder. You can get it off the SAMHSA website. We're always open and available to talk to you about our process and what that looked like. The picnic, iCloudy, you can just Google that, has an enormous amount of resources, videos, webinars to helping understand addiction, to what that looks like with substance use disorder, to the goal of being able to start screening 100% of mothers for substance use disorder during pregnancy. The Project Cara in Mayheck is fantastic. They have been a great mentor to us and really guided us. Melinda there is really top notch and is just very dynamic and able to encourage providers. Oftentimes providers have some hesitancy, and it takes someone like Dr. Suda or Melinda to be able to say, this is possible. You know, you wouldn't say to a patient who's pregnant, who has diabetes, you know, oh, I'm sorry, I can't treat you. You've got diabetes. You would never do that. And they're trying to get this like as a chronic disease to be able to accept patients with substance use disorder as well. And then the UNC Horizons program is just top notch as well. That's where we aspire to be, hopefully in 10 years, but we're just getting started. So there's some great resources for you. And then I would love to turn it over to our host. And if you want to be able to field questions either by muting and unmuting or through the chat box, just let us know what we can do. And Dr. Suda and I are here to answer questions.
Thanks so much, Gina and Dr. Suda. If you all have questions, feel free to put them in the chat, or if you'd like to unmute, I am totally happy to have you unmute and ask your questions directly. There was one comment in the chat that said, in our area, THC abuse is not viewed as serious as other substances, so I feel it is often dismissed. Is that something that you all see kind of across the board?
Marijuana use is kind of dismissed in their area.
Yeah, we have a similar problem. We were talking to the child welfare people. In fact, I'm going to be possibly presenting to them on marijuana and child custody determinations. Not that we want to make it more difficult for mothers, but we just cannot give marijuana a free pass. You know, there was an article not too long ago that looked at polling marijuana dispensaries in the state of Colorado where it's been legalized, and 62% of the dispensaries said it's a good drug to use in pregnancy for nausea, vomiting. Well, it's a good drug to use for nausea, vomiting, but not in pregnancy. We've got all kinds of substitutes for marijuana for nausea, vomiting that don't have any impact on the migration of neurons into the brain. So, you know, we got to be real careful. And it's a very easy mistake and the conclusion to draw when marijuana is being legalized in many, many states that it must be safe, you know. But if you look at, you know, its colleague, alcohol, it's the worst teratogen that we know of. It causes more birth defects than any other drug that we see commonly used. And it's a perfectly legal drug. So legalization and safety in pregnancy are not commensurate. They're not equal.
Thank you. Any other questions from our audience?
So I see one here that says, how do communities start the conversation and put MOUs in place to ensure that individuals can be given the full support needed? Should it be substance abuse programs, social services, etc.? That is it. Thank you for asking that. I had the exact same question when we first started this. I can tell you that building a structure with an oversight team and then a steering committee was the way we did that, so that you had everyone at the table with equal kind of buy-in power. So, you know, for it to be led by just one agency, I think will damage the possibility of it really being a collaboration. So although I'm funded by the Cabarrus Partnership for Children, I don't represent that agency or that sector during our meetings. My goal in my facilitation is to make sure every single sector has a voice. And I know that in theory, that's what everybody tries to do, but I can't emphasize enough that that's important. You will want to start with having an OB champion. If you don't have that in place, if you don't have an OB who's willing to see patients with a substance use disorder, you can get all the other ones on board and it's not going to happen. So if you had to start somewhere, it would be there. And then you would form these committees in order to be able to get representation from all of the sectors.
I couldn't agree more. I was very fortuitous in that I was the OB champion for Cabarrus, Rowan, and Stanley counties in the Pregnancy Medical Home Initiative when the substance use disorder clinical pathway was written up in 2014. And I was also very close to retirement, so that I spent, after I saw the clinical pathway in my hand and read it, I said, oh gosh, this is really intriguing, because if this really could get off the ground, it would be a real answer to a problem that I lived with for 35 to 40 years as an obstetrician. And so the committee, starting with an obstetrician is a great way to do it. It's going to be hard to find a candidate because obstetricians are very, very busy people, and these patients do take up a lot of time. However, that's where the public health and private medicine collaboration comes into play. As the medical director for the Cabarrus Health Alliance, which is the public health department for Cabarrus County, I was encouraged to do this as a public health measure. And I saw it as having all kinds of possibilities, while I still only delivered one day a week, which was on Tuesdays, every Tuesday. And when I retired in July of 2018, I retired from acute care medicine, so I didn't have any more hospital work. And it's really helped me to focus on this project because Gina joined us in January of 2019, and we've really taken off because of that. I think that trying to find a public health centrist approach, is not a bad idea, and getting someone who doesn't have a whole lot of time committed to doing gynecologic surgery and obstetrical deliveries and C-sections, all these things which really have to take precedence because of the acute care nature of them over substance use disorder management. So I think to a certain extent, I was very fortunate in being at a twilight of my career to start this, but maybe that's where it has to start, or unless you have a young obstetrician in a public health setting who is interested in doing this and doesn't have a whole lot of acute care responsibilities that would hinder his or her approach into doing this, because it is a time commitment.
Thank you, Dr. Suda. I got another direct message, and I want to thank you for this comment. It says, I want to see the voice of the child care community included in these discussions, because we have children when moms are in programs, and oftentimes we see things are missed. And I couldn't agree with you more. And we don't have the child care community directly at our monthly care coordination team meetings. We're new enough in our project where we're just starting to see kind of a cohort in the postpartum period. And I love that you pointed that out.
Yes.
We have the care mark, or formerly CC4C, part of the monthly care coordination team meetings, and they're the ones who are supposed to be assessing the child, and we get reports that way, and that has been our link. But I think you bring up a very good point in that.
Well, I would like to thank Gina and Dr. Suda again for sharing this really important work for both of us, for all of us to hear. It's really inspiring to know what's happening in Cabarrus County, and obviously an issue that all of North Carolina is dealing with right now. I have a few important announcements that I want to let all of you know about. One is that the session survey link is in the chat. and also up on the conference website. So we encourage you all to go on and tell everyone how great the session was. Also, we have a grand prize raffle that you can win by attending all the sponsor sessions, and our first one comes up in just 15 minutes. So get ready for that. And then I have one more piece of news to share from one of our sponsors. Pardon me while I'm having just a minor little technical difficulty. There we go.
Woohoo! It's giveaway time, guys. It's giveaway time. Jamal here from Lakeshore. We're about to have some fun. I wish I could be with everybody right now, but guess what? If we were all together, I would be giving away some kind of goodies, some prizes, something. So that's what time it is. I hope you all enjoy. Can't wait to see you next year. Have a good one. Thank you.
So our winner from this session is, I'm picking right now, Nicole Blevins. Nicole, if you will send your email to conference@smartstart.org, we will get your prize out to you. Thank you again, everybody, and we look forward to seeing you at the 3:15 session.
Sarah, thank you so much for this opportunity.